Good morning. My name is AJ Emami. I'm a practicing otolaryngologist in Tucson, Arizona. I'm a part of Valley ENT. And I would like to take a little bit of time this morning to talk about a subject that comes up all the time, which is chronic cough, the diagnosis and management of chronic cough. Neither I nor any member of the planning committee have any actual or potential conflict of interest in relation to this presentation. Our objectives today are to talk about common etiologies of chronic cough, discuss an adequate and relevant workup of chronic cough, talk about some treatment options, and then discuss some areas of controversy and possibly some treatment failure areas. So let's talk about some definitions. This talk is really geared towards a chronic cough that is dry or mostly dry, a nuisance, something that a patient is living with for an extended period of time, greater than 8 weeks. And it's really not about a type of cough that would be highly purulent or be associated with a significant amount of dyspnea, shortness of breath, desaturation, serious illness. That's an entirely different topic, and it will be covered in a different talk at some point. So the definition of the type of cough that we are talking about is really chronic cough, dry cough that's lasting greater than eight weeks. The term refractory cough refers to a type of cough that is not responding to the usual medical treatments that we would undertake, and a significant portion of patients with chronic cough are going to have refractory cough. Idiopathic cough is a type of cough that doesn't have an identifiable underlying cause after a thorough workup. Now, traditionally, this type of cough has been considered about 50% or so of patients with chronic cough are going to have idiopathic cough. However, those numbers are really kind of changing, and we're starting to be able to identify the nature of the cough and the underlying causes significantly more. Chronic cough is a significant presenting complaint. It's present in a significant portion of the general population, and it's the fifth most common presenting symptoms for patients who are seeking medical help. The costs are huge. Just the over-the-counter costs are greater than $7 billion per year, and there's a significant amount of morbidity involved with chronic cough. The quality of life measures in these patients compared to patients with diabetes, with depression, and with asthma. Morbidity in these patients can be physical, it can be psychological, and it can be social. So from a physical standpoint, these patients oftentimes have significant amount of emesis or incontinence that can be very difficult to control. Psychologically, there's a great deal of depression and anxiety that goes along with the chronic cough. And socially, these patients can have restrictions of their activities and significant amount of embarrassment. And so it's a serious condition with serious morbidity, even though it may just be a dry, nagging cough that has gone on for quite a long time. Some of the etiologies we're going to talk about are the common underlying etiologies of chronic cough. And these include reflux disease, rhinosinusitis, reactive airway disease or asthma, medication side effects, and my personal favorite, which is neuropathic cough, which is something that's overlooked quite often. So a patient comes to the office with chronic cough. Obviously, the first thing to do is to take a thorough history. Taking a thorough history is absolutely important in these patients. And of special interest to us is whether or not the cough is productive or not. Is it exacerbated by different times of day or night? Is it associated with certain positions? Are there triggers that initiate the cough or make it worse? And so those are incredibly important. And we will go through a little bit later in the talk about why each one of those things is important. Taking a history of medications is also very important, especially antihypertensives, and we'll talk about that in a little bit. And a thorough review of systems, including problems with sinonasal symptoms, postnasal drainage, dysphagia, sour taste in the mouth, as well as wheezing or shortness of breath. Physical examination should include a thorough examination of the ears, nose, and throat, looking especially for any problems of the external auditory canal, of the nasal cavity, the turbinates, the the pharyngeal wall to look for postnasal drainage, pulmonary and cardiac examination to look for other causes of shortness of breath, and especially listen for wheezing in the chest fields. Reflux is a common underlying etiology of chronic cough. It can be associated with acidic or non-acidic reflux. It may be vaguely mediated or as a direct irritation of the airway, and we see both of those things. About 20% of the general population has some reflux symptoms, and so this is a very common condition. And so it stands to reason that it can be a common cause of chronic cough. The silent variety of reflux is of especial importance to us because these patients don't have a great deal of heartburn. And so we call these silent refluxers or occult refluxers. And those are the patients that are sometimes misdiagnosed as having other underlying conditions and not reflux. So the percentage of patients with chronic cough with reflux as their underlying etiology is very controversial. There are some papers that report a high percentage of being caused by reflux and other papers less. But everybody agrees that reflux, it really is a common etiology of chronic cough. So in the 1990s, people started to think about gastroesophageal reflux as being a common cause of chronic cough. However, a lot of these patients didn't really have esophagitis when they had their endoscopy or their barium swallow. And so people like Dr. Kaufman and others started to use the term laryngopharyngeal reflux or extraesophageal reflux. And this is a term that refers to gastroesophageal reflux without the typical findings of gastroesophageal reflux disease, which is mainly esophagitis. And so these patients really present mostly with throat clearing, with a sensation of a foreign body in the throat, with postnasal drainage, with hoarseness, with dysphagia. And if you take all comers with extraesophageal reflux or laryngopharyngeal reflux, about 50% of those patients are going to have chronic cough. So a huge association between the two. Diagnostic studies for reflux include endoscopy, both laryngoscopy as well as esophagoscopy and gastroscopy, barium swallow studies, 24-hour pH monitorings, or even 48 or even 72-hour pH monitoring can be employed, and manometry. However, most practice guidelines actually recommend against a thorough workup, and they recommend empiric treatment. Empiric treatment can oftentimes result in the diagnosis being confirmed if there is a suspicion for reflux being the underlying cause of cough. What are some of the endoscopic findings that we look for as otolaryngologists? Well, the number one thing that we see is laryngeal hyperemia, red larynx. Now that's common in most types of irritations of the larynx, and almost all patients with chronic cough, you're going to have some degree of laryngeal hyperemia. However, if there is a concomitant presence of posterior commissure hypertrophy and very thick endolaryngeal mucus, then the diagnosis is reinforced. Another thing that we quite often see is severe vocal cord edema, especially in a patient who is a non-smoker. If we see a significant amount of vocal cord edema, then we do suspect gastroesophageal reflux as a cause. Treatment of reflux, of laryngopharyngeal reflux or extraesophageal reflux, is very similar to treatment of gastroesophageal reflux disease. It's based on proton pump inhibitor therapy, H2 antagonists, dietary modifications, especially fried foods, tomato-based sauces, as well as lifestyle modifications such as not eating late, such as head of bed elevation, and in a small percentage of patients, surgical interventions such as a Nissen fundoplication may actually be helpful as well. Unfortunately, treatment failures are relatively common. So why? Well, the number one reason is non-compliance. It's very difficult to do the dietary restrictions and the lifestyle modifications that we're looking for. and a lot of patients don't do it. But the second most common reason for treatment failure is the duration of therapy. The duration of therapy for treatment of laryngopharyngeal reflux is totally different from gastroesophageal reflux disease. Generally, 2 to 4 weeks for gastroesophageal reflux disease, 12 weeks or more for laryngopharyngeal reflux. And so patients oftentimes get treated for 2 to 3 or 4 weeks, and they don't see a substantial amount of improvement, and then they give up on their treatment. Whereas if those patients had stayed on for 8, 12, 16 weeks, we would have seen a significant amount. In my own practice, I don't even see my patients back for about 12 weeks because I want them to be on that treatment for a prolonged period of time before we try a sequential other empiric therapy. Incomplete acid suppression, certainly if you use a single agent or if you don't use a high enough dose of the proton pump inhibitor therapy, that can be a problem. And non-acidic reflux in patients who have an incompetent lower esophageal sphincter, you can have non-acidic reflux, so no matter how much medication is used to increase the pH of the stomach contents, they still have symptoms. And of course, incorrect diagnosis. Another common cause of chronic cough is rhinosinusitis. Rhinosinusitis is associated with postnasal drainage in a large majority of patients with rhinosinusitis. And this causes the postnasal drainage syndrome. It's also called upper airway cough syndrome. It can be due to rhinitis, sinusitis, or rhinosinusitis. So it could be due to allergic rhinitis, medication-caused rhinitis, pregnancy-induced rhinitis, or it can be due to sinusitis, be it bacterial or non-bacterial, with polyps or without polyposis. Postnasal drainage is an extremely common findings in rhinosinusitis, and it's associated with cough. The incidence is a significant percentage of patients with chronic rhinosinusitis are going to have chronic cough, and it can be the only presenting symptom in up to about a fifth of those patients. Allergic rhinitis is a very common cause of rhinitis in general. It can be present in 30 to 40% of the population. Treatment, of course, is with nasal steroids, selective histamine blockers, as well as leukotriene inhibitors. Leukotriene inhibitors are especially helpful, and they can reduce the incidence and duration of the cough significantly and very quickly. In some patients, allergy immunotherapy can also be employed, but in these patients, I want you to be cautious because the treatment duration has to be 6, 9, 12 months before they see substantial benefit. And so significant amount of time can elapse before immunotherapy can be of significant help. Treatment of sinusitis, on the other hand, is really mostly based on saline irrigation, topical antihistamines, as well as systemic antihistamines and decongestants, and a large majority of patients really do much better with a prolonged course of antibiotics. In certain percentage of patients, we have to start thinking about surgical interventions, and these surgical interventions can be in-office procedures. They can be very simple, from a 10 or 15-minute office procedure, all the way up to complex operative cases to resolve their sinusitis. So resolution of sinusitis often leads to resolution of the chronic cough. Many pulmonary conditions can cause chronic cough. And these can include asthma, COPD, eosinophilic bronchitis, which is an entity that is on the rise. We don't really know why. And so if you suspect a pulmonary cause, asthma or reactive airway disease, these can be objectively validated. And spirometry is an extremely useful and easy to do objective test with a diminished FEV1 and reversibility. Bronchoprovocation tests can be very helpful. Exhaled nitric oxide. And most commonly employed are trials of inhaled or oral corticosteroids, which usually lead to significant degree of improvement. Of special interest to us is what's called is a type of asthma called cough variant asthma. And cough variant asthma is also called cough variant reactive airway disease. It's usually exacerbated by an upper respiratory infection, and it's much worse at night or early morning hours. And so those are clues to lead you to think that a patient who is not wheezing, who doesn't have any shortness of breath, may have asthma as their underlying cause of their chronic cough. In these patients, it is required that they actually get better with a trial of inhaled corticosteroids or oral corticosteroids. and that can be your clue that the cough variant asthma exists. And then that can be subsequently validated with objective testing. Leukotriene inhibitors are incredibly helpful, as mentioned before. They take about a week or so before they start doing anything, and the improvement continues for up to about a month of therapy. Medication side effects is something that we should always think about. Angiotensin ACE inhibitors are the #1 cause of medication-induced chronic cough, and about 10 to 15% of patients on ACE inhibitors actually require the withdrawal of the ACE inhibitor because of development of severe chronic cough. And so the point to remember about ACE inhibitors is that the chronic cough can develop at any time during therapy. So a patient can be on the medication for a prolonged period of time, months or years, and then develop chronic cough. And as soon as the medication is withdrawn, the chronic cough goes away. So don't think that it's not the medication because they've been on it for a prolonged period of time. Other medications to also think about are NSAIDs and beta blockers. Why? Because these actually make bronchospasm significantly worse, and they can lead to a patient who has maybe a very mild version of cough variant asthma to develop significant cough. And so if you withdraw those medications that are making the bronchospasm worse, then an improvement can be seen very quickly. Of note is that angiotensin receptor inhibitors, okay, so things like losartan, are not known to cause cough. And as a matter of fact, their cough profile is very similar to placebo. And so they can be easily switched from ACE inhibitors to that class of medications. A relatively newly described condition is called neuropathic cough. Actually, during my fellowship, I was part of the original group that described this condition. We called it irritable larynx syndrome at the time. And subsequently, it's been better known and described as upper airway hypersensitivity or cough hypersensitivity syndrome. It's basically a post-viral vagal neuropathy that affects the recurrent laryngeal nerve or the superior laryngeal nerve. And so these patients develop a severe cough, oftentimes from another underlying condition, and then the cough gets a life of its own. And then because they've developed this neuropathy, they continue to cough despite the fact that their other underlying condition may have resolved. So it's now thought that up to about a third of patients with neuropathic cough, with refractory cough, actually have neuropathic cough, and they've just not been diagnosed correctly. Similar to other neuralgias, they have trigger phenomena associated with it, and they respond to neuropathic modulators. And so their triggers are oftentimes strong odors, smoke, talking or laughter, and sometimes they're actually even associated with shortness of breath and stridor and paradoxical vocal cord motion syndrome. Initially, when we first described this condition, the treatment of choice was long-term narcotics and opioids, because these medications are very good as cough suppressants. And unfortunately, we weren't quite aware of how addictive they really were. And as time has gone on, we've really kind of pushed that aside. Now we really try to go with the neuromodulator treatments, things like amitriptyline and gabapentin. And occasionally, we use some muscle relaxants and even botulinum toxin injection into the larynx. And sometimes I will go ahead and do this for patients with severe refractory cough who I know have neuropathic cause and have not responded to other medications. So gabapentin is my drug of choice. Amitriptyline is also just as good. The treatment effect takes up to about 4 to 6 weeks. So again, patience is required, and the dose has to be increased generally to at least the gabapentin, about 600 milligrams a day, divided in 2 doses or 3 doses. And the treatment continues to work and has to be continued for up to about 6 months before it's starting to be withdrawn. Be aware of the side effects: sedation, dry mouth, postural hypertension. Those have all been described. Other interesting etiologies for chronic cough that we are going to discuss quickly are obstructive sleep apnea, ear cough reflex, and psychogenic cough. Let's talk about these very briefly. So obstructive sleep apnea is a very common condition. It affects about 10 to 15% of the adult population in the United States. And it can be, and if you take all comers with obstructive sleep apnea, up to about a third have chronic cough associated with it. We also know that in patients with obstructive sleep apnea, they have a much higher incidence of gastroesophageal reflux as well as rhinitis. And so it may be the obstructive sleep apnea that's the cause, or it may be the conditions that are associated with it. We don't really know. But in a certain percentage of patients, cough may be their only presenting symptom. So if a patient comes in with other parameters that make you suspicious for obstructive sleep apnea with chronic cough, always think about obstructive sleep apnea. Another interesting etiology is the ear cough reflex, otherwise known as Arnold's reflex. It's due to the presence of the vagal nerve has an auricular branch that was originally described by Friedrich Arnold. And an irritation of any type of the external auditory canal can lead to cough. And we see this very commonly when we're cleaning cerumen out of an ear. The patient starts to cough. And that's the Arnold reflex. And if there's a chronic irritation, you can have a chronic cough simply because you have an irritation in the external auditory canal. Psychogenic cough is a diagnosis of exclusion. Once the thorough workup has been undertaken and there is no other factors that you can think of, and the patient may be prone to this type of thing, you can think of a habit cough or a tic cough. It's absent always during sleep, which is a big clue as to if it's neurogenic versus psychogenic. And it sometimes responds to suggestion therapy, hypnosis, relaxation therapy, and voice therapy. So in summary, the initial workup of a patient with chronic cough should of course include history and physical examination, a chest x-ray to rule out underlying infiltrates or other etiologies. And spirometry should be considered in patients who have any suspicion of reactive airway disease being the cause of it. Clinical practice guidelines recommend sequential empiric therapy based on findings, and in most patients, 70 to 80% of patients, the chronic cough can be managed very well without, by following these clinical practice guidelines. Neuropathic cough, otherwise known as irritable larynx syndrome, hypersensitivity cough, also another term for it, is a commonly overlooked cause. So if you have eliminated other causes, think about neuromodulators. A significant portion of these patients are going to have multiple etiologies, so a multidisciplinary approach, including pulmonology, otolaryngology, gastroenterology, may be of significant benefit for these patients. A lot of patients can present with cough as the initial symptom of other underlying conditions. So it's very important to keep an open mind. Thank you very much.